Thanks for the organizers and thank you everyone for coming here for the CME. And I'm Dr. Harish, working as a consultant medical oncology at Yashoda Hospitals. Today in the next 20 minutes, I'll be talking about the most common gynecological cancers and the role of chemotherapy and newer agents like targeted therapy and immunotherapy. And as we all seen the previous presentation and subsequent presentations, the most common modalities of treatment in the gynecological cancers are surgery and radiation therapy. But the role of chemotherapy comes in the picture once we are becomes unresectable after getting surgery done or along with the along with the radiation. The role of chemotherapy will just augment and prevent the recurrences and just to take out the micrometastasis which has already been there. And apart from that, in spite of so many screening modalities and awareness, most of our patients do present with advanced stages where were only left with giving with palliative chemotherapy. And in the recent days, in last 10 years, we have newer drugs in the market where we can help our patient to prolong their survival and improve the quality of life with lesser side effects and more quality of life and improve several items compared to the chemotherapy. So we have out of our more commonly we see a lot of ovarian cancers, endometrial cancers, and cervical cancer. In India, the most commonly we see cervical cancers, and most deadly of them is ovarian cancer. So first, I discuss with start with the endometrial cancers, where we are when you have a stage 4 disease, advanced endometrial cancer, and when they present with upfront or subsequently after taking the localized treatment. When they present upfront metastatic disease, the most of the cases do present with stage 1 and stage 2, and most commonly the postmenopausal stage. But when they present in the most like around 20% advanced stages, stage 3 and 4 upfront, where we can still try curative intent with when they have an abdominal disease, we can do the same CRS as we do in ovarian cancers, and we can take it the adjuvant chemotherapy if their disease is limited in the abdominal, just extrapolate beyond that. So when they have recurrence and after local treatment, and when they present with distant metastatic disease, where we have to treat with the chemotherapy followed by along with additional targeted therapy or immunotherapy, that which I will discuss now. So historically, we divide the uterine cancers into type 1 and type 2, where we see these alterations in the type 1 cancers. Type 1 cancers more of like low-grade endometrioid. They were to present very early stages, like stage 1 and 2. And we do see like PIK3CA, PTEN mutations, and more of adenine mutations in the clear cell histologies. And in type 2, where we see the aggressive part of it, like where they present the advanced stages like stage 3, 4, and serous variety, where we see the TP53 mutations as well as the HER2 mutations, and sometimes BRCA1 and 2 more are commonly seen in the type 2 varieties. And so this is the historical classification, but this has some limitation because of the overlapping of these mutations in type 1 and type 2. And the recent genomic and proteomic and transcriptome analysis like TCGA, where we have classified our tumors into this newer molecular classification, where we have type of pole mutation positive, and someone having MSA high, and someone having copy number low variations and copy number high. So how does these do help us? So in this we can see the MSI high, that is the microsatellite instability, where we can have these tumors do have very good prognosis, and they do more of neoantigen formation, which helps in the immunotherapy role. And other is in copy number low variety, it is very good prognosis because of the lower burden of the mutations. And as I mentioned, this we'll see most of these MSA status positive tumors in the Lynch syndrome, where these tumors have inherent potential to have more of high mutation burden, that is called tumor mutation burden. We measure it with new advanced techniques, where we can see that when there is a lot of neoantigens in our body, they just incite the more of immunity, which will helps them, which indirectly helps that they are more responsive to the immunotherapy. So we do test these markers on the immunohistochemistry, where the specimen, either biopsy or histopath specimen available. We do this testing like microsatellite instability, deficient MMR proteins, and sometimes when they're not detectable, we do prefer the NGS as well. So whenever have these advanced cases, what are the tests we have to see? First and most important is the type of histology. Of course, endometrioid cancers and serous cancer both have different biology. So they are we have to treat in a different way, whether the patient has symptoms or not. If they have symptoms and endometrioid and low burden of disease, still they do get away with the simple hormonal therapy. That is, the histology is very important. And we test for the ERPR status as well the HER2/neu. And we do test for these immunotherapy markers like MSI, both MSI and DDMA, and tumor mutation burden. We consider as high only if there are more than 10 mutations per megabase. And targeted NGS will help in the desperate cases where we are all come negative and the patient is not responding to what are the available treatments, and still the patient is fit enough to take the further treatment. So these are current recommendations for what we do for the relapsed recurrent endometrial cancers. So more or like hormonal therapy, chemotherapy, and targeted therapy in terms of lenvatinib, and in some cases bevacizumab, and advanced in second and third line we prefer pembrolizumab and dostarlimab based on the MSA status or their TMB status. So till today, the current standard of care for last 2 decades or 3 decades is this chemotherapy. Upfront, this is the trial where the chemotherapy was state of standard of care, that paclitaxel carboplatin, when it was compared with the 3-drug regimen, it is better than 3-drug regimen, and the survival of more the median PFS around 13 months for the upfront paclitaxel carboplatin when they compared with the 3-drug regimen. Adding doxorubicin did not value much. So median OS with simple chemotherapy itself goes up to 40 months. So this is the keynote 158 update, where after progression of the chemotherapy, what we are left with the second line options. The role of immunotherapy came up with this trial, where they have used pembrolizumab who have failed the first line platinum based chemotherapy. In this trial, there was only those tumors which have this MSA high status or MMR status high, and PDL1 tumors, they have the response like up to 48%, and they have duration. Some patients, the duration went up to 54 months when they have responded beautifully. And this is another trial. The dostarlimab is the drug, is just like brother of pembrolizumab. This drug recently came into the media with so much hype, which has cured most of the rectal cancer patients users. And that's not the case, as we all know. Apart from that hype, because these drugs are helpful only in those cases where we have MSA status high or they have a high mutation burden indirectly. So this drug is approved for the endometrial cancer as well, based on the phase 1 study, and it has a tumor agnostic indication. Tumor agnostic means it can be used in any cancer when the status of MSA high is available or if the tumor has TMB high. So based on this trial, this drug can be used in the second line when the patients have progressed on their first line chemotherapy, and apart from the pembrolizumab. So when the patient doesn't have any of these markers positive, like MSA stable, that is normal MSA status, and no mutation burden is very low. So we can try this second line chemotherapy, after second line agents, we can try lenvatinib and pembrolizumab. Lenvatinib is basically TKI, which is a multi-kinetic tyrosine kinase inhibitor, along with pembrolizumab. When added in the second line after progression on the chemotherapy, it has a response rate of around 30%, and along with the duration of response led up to almost 14 months, and there are survival benefit of apart from the second line chemotherapy, additional 6 to 8 months of survival advantage. So these are PFS curves. These are when it has been shown the benefit in spite of the PMR status stable. So we have discussed that pembrolizumab, dostarlimab are helpful only in those cases where MSA is high. But this regimen has done the benefit even the status is MSA is stable or the patient has MMR proficient. And another marker we test for in those cases when they are presented with upfront metastatic disease or recurrence with extensive burden, where we can see HER2/neu biomarker which is commonly used for stomach and breast cancers. This marker is based on the phase 2 data where we have role of this marker when they have ISC 3+. So we can still add this drug to the chemotherapy where it increases the survival almost up to median survival goes up to 18 months, 18 months in those patients where have ISC 3. So what in this, after our discussion, I can tell how you have to approach a case when they have a stage 4 metastatic endometrial cancer. First, we have to test for the HER2 status. If it is positive, we can give paclitaxel and trastuzumab. If it is negative, we can have only get away with paclitaxel carboplatin. We can take survival up to median progression survival up to for 13 months. In the second line, we can see whether the patient has this MSA status high or not. If yes, then we can try pembrolizumab or dostarlimab. If not, we can give pembrolizumab lenvatinib. And I'll go to the next topic, ovarian cancers. This is one of the common cancers and most deadliest among the gynecological cancers. And we all, the same classification, like traditionally we use the type 1 and type 2 ovarian cancers based on their histology and aggressiveness and stage of presentation. So most commonly we see type 2 in ovarian cancer cases where we see more of P50 mutated and BRCA positive, high-grade serous cancers. Every histology has its own like alterations genetically. Sometimes if you see the high-grade serous, it has more of P53 mutations and BRCA positivity and HRD positivity indirectly. And some mucinous tumors we have like colon cancer, they do have KRAS pathway involvement, and some endometrial cancers do have PTEN mutations, and some clear cell cancers do have IDA1 mutations. And apart from that, we have rarer varieties like sarcoma components, and that are mutation negative. So in early stage ovarian cancer, how I treat? Generally, when they present with upfront stage 1 or 2, we first suggest we go with surgery first, that is primary cytoreductive surgery. And most of the patients, when they have grade, even with stage 1 and grade 3 high-grade carcinomas, and stage 1C, when they have rupture or spillage, or stage 2, needs adjuvant chemotherapy after complete cytoreductive surgery. We give the IV paclitaxel carboplatin 3 weekly, 3 to 6 sessions. In stage 1, if stage 2, we give it the complete 6 cycles. If the patient is elderly, we can get away with only single agent carboplatin. In advanced cases, after primary cytoreductive surgery or NACT, if they have taken prior, will complete the 6 sessions of chemotherapy with the same regimen. So this is the standard of care as of today, and what extra we can do on top of it just to improve the survival. Surgery, chemotherapy, and 6 sessions. On top of it, we can add some drugs especially targeted drugs like bevacizumab and PARP inhibitors like olaparib and MEK inhibitors like tremelimumab in the ovarian cancers. So when the role of bevacizumab comes, it's like anti-angiogenesis inhibitor where it prevents the neoangiogenesis in the tumor. So this drug helps in only those cases we have suboptimal cytoreduction, and when they have gross ascites at presentation, and when they have gross effusion, pleural effusion, stage 4B. So in those cases, though after the primary cytoreduction surgery done or interval cytoreduction surgery is done, still these patients do relapse early. So on top of chemotherapy, we can add this bevacizumab just to improve the progression-free survival. And apart from that bevacizumab, what else we can add on the maintenance once they finish their treatment, once they have got the surgery done and they have received the chemotherapy, and what else can done on follow-up just to prevent the early recurrences. So these days ovarian cancers, in all ovarian cancers, all the current guidelines do suggest to test for BRCA or HRD if available. So why it is like that? So because after the current data suggests most of our ovarian cancers, most commonly the serous cancers, are related with homologous recombinant deficiency, HRD status. So 50% of all of ovarian cancers, every second patient is having HRD positivity, and each HRD positivity is indirectly because of germline or somatic BRCA mutation. And rest of 25%, we don't know exactly, but there are other targets like other mutations like RAD and PALB, which can also lead to the this HRD status. That is, they are deficient in the homologous recombination repair. The same thing. So how to do test? How do we have to test it? So we do suggest for BRCA mutation we can do the PCR, or for HRD status we test just the genomic instability. We make a score out of 100, which HRD there's specific panels we have for HRD testing where we test the loss of heterozygosity and telomeric instability, and apart from large scale transitions. These three count up to make up the another effect of this HRD. This basically the tumor is not able to just make the repair properly. So single gene testing is available and NGS testing is available. And so since the development of bevacizumab as part of the treatment regimens, bevacizumab since 2011, there are other new drugs in the last 10 years, they're like olaparib, veliparib, and these all paribs, when they have shown to be benefit in a BRCA related cancers in the advanced setting like second and third line, they have taken into upfront just to prevent the early recurrences. How does do they act? Basically they basically just like they trap the PARP enzyme, which is essential for the inhibition. They help in only those cases where they have BRCA mutation which led to the deficiency in the single strand breakage repair. So these are the 3 trials which have shown the benefit of upfront PARP inhibitors as a maintenance after completion of your chemotherapy. Like a solo 1 trial where we have olaparib maintenance, and Prima trial we can use olaparib, and Paola 1 where we use the both olaparib and bevacizumab. So just a gist of it is all these drugs are advisable after treating these cases with advanced like stage 3 and 4 where we can give as maintenance, or up to 36 months when they have germline BRCA mutation positive. In some cases we can still try in somatic BRCA as well. And when they don't have any BRCA mutation positivity, we can still give niraparib, because with underlying HRD status which has helped in the trials that is shown that they have late recurrences when you add the PARP inhibitors as maintenance. So what to choose? In a first line maintenance, if it's BRCA wild type, we can give niraparib. If it is as a maintenance, if it is BRCA positive, we can try any of these 3 drugs. So still a long way to go even if after most of the cases when they are recurrent, when they can be platinum sensitive or platinum resistant. Platinum sensitivity is as defined as more than 6 months from the last platinum infusion. So, or if they have recurrence within the 6 months, that makes the disease very resistant. So, there are only few drugs available for those platinum resistant disease. These days we have antibody drug conjugates and immunotherapy trials are going on for these platinum resistant disease. Still the outcomes are very dismal. So next come to the most common cancer in India, gynecological cancer in India, like cervical cancer. When they have a recurrence in upfront and as a metastatic disease, or when they have presented with the local, when have metastatic disease after completion of their local treatment. So there are 2 things. When they have the recurrence, whether they have single central pelvic recurrence or extensive burden. When they have a single central pelvic recurrence with less than 3 centimeter, or they have not treated with radiotherapy previously, and we can try with the curative intent with redo surgery or radiation, and especially when we cannot do the further radiation and surgery is not possible, and patient has a metastatic disease which is not resectable, where we have to give it the palliative chemotherapy with addition of immunotherapy if they are MSI positive. So still standard of care is paclitaxel carboplatin or cisplatin. If the patient is not received cisplatin as a part of the radiation, then we can give the study with the cisplatin, or else if patient hasn't received the cisplatin, even carboplatin will do the same job. So in a metastatic disease, what are the markers we have to look for in when they have presented the metastatic? PD-L1 testing, as suggested in the endometrial cancer, both same test will help us whether the patient is eligible for immunotherapy or not. And apart from that, if the CPS score is more than 10, definitely the pembrolizumab addition to the chemotherapy will prolong the survival and along with improving the quality of life. This is the trial. Recently, the drug got approved in last 4 months back, where the addition of bevacizumab plus pembrolizumab to the chemotherapy if they have MSI positivity, compared to the chemotherapy plus bevacizumab, they have improved the survival at least by at 1 year. The survival rate is almost doubling, and the survival curves are, you can see there is a like tailing where can you start flattening of curves. Sometimes there are long standing responders when they respond beautifully with immunotherapy. So when they have already taken chemotherapy and came to you like after progressive disease, if I have not received the immunotherapy upfront, because most of our cases did not probably they are not affordable or not received because of the financial limitations, or the just like when they have not got tested for any MSS status in the upfront. So when they present to you in advanced state where they have taken chemotherapy for second line, where we can try immunotherapy, if the CPS scoring, this CPS scoring like is basically combined proportion score, where we say the number of tumor cells are positive for PDL1. So if the score is more than 1, so we can give single agent pembrolizumab, which gives a survival rate of at least 8 to 12 months and response rate of 30 to 40%. So when have all the options are left, the patient is fit enough. This is the new drug which got approval for cervical cancer, like tisotumab vedotin. It's basically antibody drug conjugate. It is a tissue-derived antibody drug conjugate along with the microtubule inhibitor. It when is given as a single agent as a third line, if I have received more than 2 lines, it still has efficacy, and compared to the standard of care and best supportive care, we can patient if is ECOG1, we can still try this drug. This drug doesn't have the side effects related like chemotherapy, more of the ocular toxicity and transaminitis. So these are the first line preferred options. In upfront, in cervical cancer, we can give pembrolizumab plus chemotherapy if MSI positive, or only chemotherapy plus bevacizumab if MSI is stable. And in second line, who have not received any immunotherapy, we can give immunotherapy as single agent, or if have received immunotherapy, we can try tisotumab. Or patient is not affordable of these agents because these agents are very costly and one of the drugs is not available in India. We can try with a single agent chemotherapy like vinorelbine or pemetrexed. Yeah. Thank you so much. If any questions, I'll take in the panel or later.